Hi, welcome. Thank you. Appreciate your coming today. Today is a tough topic and one that is not easy to deal with, even for professionals in the area. Before we begin today, I'd like to just start off with an announcement. Everybody could, if you haven't already, turn off your cell phones and other devices that could provide distraction for us during the program. Before I get into today's program, I'd like to announce that in July we have a very special program and at a special time. Governor Christine Gregoire will be here to speak to the City Club about challenges and opportunities we face in Washington State and her vision for our future. And you know, we're not in the best of shape financially now. We've just been through a very vigorous and rigorous session in Olympia. But to accommodate the governor's schedule, we can't meet at our regular time. So we have it 2 days early on Monday the 25th. And sadly, we can't be here because there's somebody else meeting here. So we will be Monday, July 25th at the Bellingham Hotel. And we'll be sending out an email with further details on this. But basically, there's going to be limited seating, so unusual for City Club. We're opening it up first for members. And if we don't have enough members who want to have seats or can have seats, then we'll open up to the general public. There will be plenty of opportunity for getting information on this. If we open it up to the public, it will be in the press and whatever. So, members, please look the next few days, probably by Friday or Saturday at the latest, for an email with information on how you can get your ticket for that event. So, an August program, on August 24th, which is our normal time, and it will be here. Dr. Bruce Shepard, President of Western, will be our guest speaker. Today's presentation is titled Conversations Before the Crisis. It's a topic that includes terms like advanced care directive and palliative care, words that trigger a rise in our anxiety, especially when they relate to us personally or to our family and friends. Today we have two speakers who will talk about end-of-life decisions in a way that offers us tools to allay some of that anxiety. Dr. Michael Massanari is the Executive Director and Director of Research for Critical Junctures Institute here in Bellingham. The Institute is a collaborative venture between Western and East Health St. Joseph. And before coming to Bellingham, Dr. Massanari was Director of the Center for Healthcare Research and Professor of Medicine and Community Medicine at Wayne State University School of Medicine in Detroit. Dr. Meg Jacobson has been a family practice physician in Bellingham for 21 years, so she's much more of a familiar face to many people around here. And she is part of the Family Care Network. She also, and perhaps more importantly for today's presentation, serves as Medical Director for Whatcom Hospice. Dr. Jacobson and Dr. Massanari are both graduates of Northwestern School of Medicine. Please welcome them as they help us grapple with this challenging issue. Dr. Jacobson.
Thank you. It's really good to be here. I see lots of familiar faces, so that makes my job much easier. It's also a little overwhelming. The last time I did an advanced care planning talk was on National Healthcare Decisions Day, which was in April, and we had 5 people show up. So this is a much bigger audience. So I'm going to start with a little patient vignette, and what we're hoping to do today really is to talk about some really exciting things that are happening in Whatcom County, nationally as well, but particularly here in Whatcom County. And I wanted to really bring this subject here today to all of you. I'm very passionate about it, so let's get started. Skip, could I have the first slide? So this is a quote from Isaac Asimov. Life is pleasant, death is peaceful. It's the transition that's troublesome. And so today we're going to talk about that transition and ways to make it less stressful. Next slide. So the first patient I'm going to tell you about is unfortunately an all too typical patient. This particular patient is a patient that was a patient in a East Coast teaching hospital. But we have patients like this now at Peace Health St. Joseph Medical Center. So this is an 87-year-old nursing home resident who had advanced dementia. And she was admitted to the hospital with loss of appetite, fever, and a diagnosis of a generalized infection that started in her urinary tract. She had no pulse, which we'll talk about later, the physician ordered for life-sustaining treatment, and she had no durable power of attorney for health care. So her estranged daughter from California was contacted and insisted on full treatment. Here and everywhere else in the country, we called that particular family member the daughter from California. Apparently in California they call it the daughter from New York, but so the estranged daughter from California was contacted and insisted on full treatment. So Mrs. R was sent to the ICU. She was placed on a ventilator. She was given antibiotics through a central line. Blood pressure support medications were used. Her underlying lung disease prevented her weaning from the ventilator. She then had a feeding tube placed and a tracheostomy placed. She had 6 weeks in the ICU, and her daughter, who visited infrequently, continued to insist that everything be done. Despite really good care, she developed multiple deep pressure ulcers with severe pain each time the dressings were changed. Her pain was not well controlled. The nursing staff was extremely distressed because they were a party to how much she was suffering. She then developed an infection with a bacteria called methicillin-resistant Staph aureus, and it developed in one of her pressure ulcers, and then it spread to her surrounding soft tissues. And her daughter finally agreed to stop treatment. She died on day 102 of her hospital stay, and the cost of care was many, many times more than $1 million. Next slide. So now I'm going to turn the discussion over to Dr. Massanari, and he's going to pick up from here.
First of all, I too would like to thank you for the invitation to join you today. What I'd like to do now, you've heard this illustrative case that May shared with you, and unfortunately it's all too familiar across the country. What I'm going to suggest that we do for the next 10 minutes or so is to step back to the 50,000-foot level and to look at how care is rendered across the country, the variability in care around these issues. And I'd like for us to think about the questions that I've set out here. First of all, how is it that we spend our final days? Secondly, what do we spend for our final days? Third, do we have choices how we spend our final days? And finally, how do we feel about how we spend our final days? And the next slide. So what I'm going to do is, in very broad brushstrokes, is to give you a picture, if you will, as to the kind of variability in care across the country. Now, this slide is taken from Medicare data, so we're looking at older people in the country, And it looks at the payment of Medicare dollars for patients' care over the last 12 months of life. And there are two things I want you to take away from this slide. Let's not worry about the details. First of all, as we near the end of life, note the increasing cost of care as we increase our intensity of care. The second thing I'd like to illustrate here is that if you look at the dark blue bars, that's dollars that are dedicated to hospital care, and notice how that constitutes most of the cost of care for Medicare patients toward the end of life. Next slide, please. Now, what we're looking at here, we're going to take a bit more focused look at three different areas in the country. University of Miami in Florida, University of California, Los Angeles Florida, UCLA in California, and La Crosse, Wisconsin. These are three quite remarkably different hospitals in the care that they provide. And what we're looking at here is the cost of care based on Medicare payments at these three institutions. And this, in contrast to the previous slide, is relatively recent information. Let's look first at University of Miami in Florida. In the last 2 years of life, if you were in that particular area of the country and received your care at the University of Miami, you could anticipate, on average, spending 40 days of your last 2 years, that'd be about 720 days, 40 days in the hospital at a cost of some $64,000. Now, keep in mind that $64,000 is Medicare costs. We're not considering here the cost of the family, for transportation, for alternative care, and so forth. We're looking solely at Medicare costs. Second, if we look at UCLA, it's a little less, but not a whole lot. You spend 31 days in the hospital at a cost of somewhere of about $60,000. And then we have La Crosse, Wisconsin, where if you live in La Crosse, the likelihood of spending time in the hospital the last 2 years, it's only about 13 days during the last 2 years, at a cost of about $18,000. Note the striking contrast. And I want to highlight here, and I'll highlight it again throughout my brief presentation. This is not a judgment on care. There is no right or wrong here. You have a choice. We have choices to make. So it's not to say that La Crosse is right or the University of Miami is right. Next slide, please. Now let's step back and look at the nation. And again, these slides are a little bit complex, but if you let me walk you through it, I'm going to try and make it as simple as possible. Again, we're looking at Medicare expenditures in the last 2 years of life. These geographic areas you see here are areas that are used by the government to, if you will, divvy up the nation and provide comparisons in terms of cost of care and services delivered and so forth. They're called metropolitan statistics areas. We have over here on the side the graphic in terms of the color, but suffice it to say, the darker the color, the more money spent in the last 2 years of life. Now, let's look at a couple of these areas. I'm having a little trouble here from this far. Los Angeles is down here in the dark area somewhere. Also, McAllen, Texas. McAllen, Texas is a smaller community. I see some of you shaking your head, where a lot of people spend their winters. It's right on the border. And they are amongst the top spenders in the country, according to Medicare. And then there's Miami, Florida, which is covered up. You'll just have to take my word for it that it is dark. Now, let's look at La Crosse, Wisconsin. La Crosse is located up here in Wisconsin, just above the Iowa border and along the Mississippi River. It's served by the Gunderson Medical Clinic and 2 hospitals. What you'll note here is that it is amongst the lowest spending geographic areas in the country. And then we have Bellingham, which is kind of tough to see up here. We're fairly low. We're not as low as Gunderson, but we're fairly low, certainly relative to Los Angeles, McAllen, Texas, and Florida. Next slide, please. Now, these slides thus far have looked at dollars spent. Economists would argue that probably is not the only or best way to look at it, because dollars spent in one area may buy more than in another. So this particular slide looks at services rendered. For example, if a patient's admitted to the hospital, do they go to the intensive care unit? If they go to the intensive care unit, do they undergo an MRI? How many chest x-rays, how many laboratory tests, and so forth. What this compares, if the nation on average is 100%, in Miami, Florida, services used are 140% of the average of the nation. Remember again, Miami is the highest spender, the highest utilizer in the country. A very close second, McAllen, Texas, at 138%. Then there's La Crosse, Wisconsin, 75% relative to the national average in terms of utilization of services, and this is the lowest in the nation. Seattle, 90%, and Bellingham, 85%. So we're considerably below the average in terms of the utilization of resources and expenditures at the end of life. Next slide, please. But now I want to step back and take a look at how we use some of those services, if you will, to get at the issue of how we spend those final days, final months of our lives. This is a similar slide of the nation with different colors, with these different geographic areas. In this case, I'm going to try and recall here because I can't read it from back here, but this looks at the likelihood of spending time in the hospital in the last, I'm sorry, I forgot whether it's year, 2 years of life, but it's toward the end of life if you have cancer or are receiving cancer care. The darker the areas, the more likely you are to spend it in the hospital. And again, if we were to look at California, Los Angeles, McAllen, Texas, Miami, Florida, you'll see that they're very dark. If we look, however, at La Crosse, Wisconsin, you see that it's very light, so that you're much less likely, if you have a diagnosis of cancer, spending it in the hospital. Next slide, please. This is a similar slide, but this looks at the likelihood that if you have cancer and are admitted to the hospital, what's the likelihood you're going to spend time in the intensive care unit? And I think it's worth considering that for a moment, that if you have cancer, we're not talking about young people here. We're not talking about someone who's had an auto accident, an accident at work, who may have a chance of survival and longevity. We're talking about people that we know have end-stage disease. And the physician has a pretty good way of knowing roughly what the prognosis is. We can't tell you whether it's weeks or months or whatever, but we can say with some reason. What we're saying here is that we're dealing with older people who are admitted to the hospital for cancer, who end up in those final days in the intensive care unit. Again, the darker the area, the more likely you are to end up in the intensive care unit. Again, what I want to illustrate is the dark areas. If you're in California, McAllen, Texas, or Miami, Florida, you're much more likely to end up in the hospital and in the intensive care unit. Now, the next two slides are going to be very brief. It looks at it another way. Give me the next slide, please. In the next slide, we're looking at the likelihood of being admitted to hospice in the last 30 days of your life with the diagnosis of cancer. Again, we see the same sort of geographic areas with their colors. And in this case, the darker the color, the more likely you are to spend time in hospice. The lighter the color, the less likely you are to spend time in hospice. California, note how light. McAllen, Texas. Miami, Florida, a little darker. And then if we look up here across Wisconsin, it's not the darkest area, but again, you have a much more greater likelihood that if you have cancer in La Crosse, Wisconsin, you will end up in hospice care at the end of life. You can't see the color very well up here in Bellingham. We're somewhere in between. You have a greater likelihood of being in hospice care at the end of life than you are if you're in California or McAllen, but less so than in La Crosse, Wisconsin. Okay, if you move ahead and go one more slide, please. Now, we've talked a bit about how people spend the last days of their life, the last months of their life, a little bit about costs. Do we have a choice? Again, there's lots of information here, and I don't have time to go into it, and Nate's going to talk to you in more detail about what we can do locally. I simply want to share the observation from this one study. And I apologize, I didn't put the credits down here, but this came from Ann Arbor, Michigan, and was published in 2010 in the New England Journal of Medicine. Very briefly, focus here. They looked at people who had living wills and people who didn't have living wills, and they looked at what happened at the end of life. If you have a living will, you're more likely, less likely, to die in the hospital. If you have a living will, you're less likely to receive all care possible. The example here again would be the case that Nate just presented to you. If you have a living will, you're more likely to receive limited care, which is what you requested. And if you have a living will, you're more likely to receive comfort care. So there are choices to be made. We can make choices. Final slide, please. So how do we feel about the way we spend these final days of life? This is an important question because this really comes out of that. You recall the, if you will, the spurious argument that arose during the healthcare debate about the death panels. And it was most unfortunate because it created a lot of problems for the kinds of things we're talking about here today. What we're simply trying to do is to get people to reflect and to look about choices they can make. And so the question is, how do people feel about it if they receive less care? I'm not giving you the references. I'll be more than happy to provide anyone that wishes references for this data, but these are summary statements. When patients and families make choices regarding end-of-life care, they usually choose less intensive care, palliative care, and/or hospice care. Secondly, when patients and families make choices regarding end-of-life care, they report greater satisfaction with care and with their caregivers, and they report less anxiety and less depression. Finally, when patients and families make choices regarding end-of-life care, the costs of care are significantly reduced. And I think we've illustrated that, and maybe we'll talk more about these choices. Thank you.
Skip to the next slide. So we talked about our first patient who was the patient with advanced dementia. And now I'm going to talk about another patient who had a completely different experience. And this is a patient who was a 72-year-old retired executive. And he fell and was taken to the hospital after a fall and had a diagnosis made of a rapidly progressive neurodegenerative disease. And because he was in an East Coast teaching hospital, they had a palliative care service, and so a palliative care consult was done and the palliative care team was asked to come and address patient and family distress. This was a very distressing diagnosis. So with the palliative care team's involvement, there were multiple discussions with the patient, family members, physicians, and other team members about natural history and prognosis of the disease. It's really important to know what the natural history of your disease is and what your prognosis is. You can't really make good decisions without knowing the prognosis. Upholds the physician order for life-sustaining treatment and a durable power of attorney for health care were executed, and a hospice referral was made because this man's prognosis was not very good. The patient then entered the hospice program, and the hospice team helped the patient write letters to his grandchildren while he was still sentient and able to participate. And there were lots of discussions about legacy with hospice social workers and chaplains. It was very important to this man to leave a legacy. Consistent with his wishes, he had a urinary tract infection and a bout of bronchitis, and these were both treated while his function and quality of life were good. And then he began to experience progressive cognitive decline. Now, this was anticipated, and so this man knew that his wife would not be able to meet his needs, and he frankly didn't want her to meet his needs, particularly his personal needs. And so together, before the decline happened, they were able, with the assistance of their hospice team, to visit several nursing homes in the area. And they picked one, and they picked one in particular because this nursing home allowed the patient to have visits from his favorite, much-loved and aging dog. So they picked a SNF that would allow those visits. A SNF stands for Skilled Nursing Facility. And he then entered the skilled nursing facility, and in the course of his time there, he developed a pneumonia. But because he had a physician order for life-sustaining treatment and had multiple discussions with his family and with his wife, no antibiotics were used to treat the pneumonia, and the patient was not transferred to the hospital. And so, with death not forestalled, he died peacefully, surrounded by his wife and children, 9 months after his diagnosis was made. Can I have the next slide? So, we're going to talk about palliative care because you heard that term, and we're going to talk about what it is and who should receive it, and what is the impact of palliative care on quality and costs, and where are we with palliative care today in Whatcom County. Next. So this is a definition from the Medicare hospice conditions of participation. Palliative care means patient and family-centered care that optimizes quality of life. And that's really important. It optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care throughout the continuum of illness involves addressing physical, intellectual, emotional, social, and spiritual needs to facilitate patient autonomy, access to information, and choice. Next slide. How does it differ from hospice? So non-hospice palliative care is appropriate at any point in a serious illness, provided at the same time as life-prolonging treatment. There's no prognosis requirement and no need to choose between treatment approaches. Hospice palliative care provides care for those in the last weeks or months of life. The hospice requirement is that you have a prognosis of 6 months or less. And patients have to give up insurance coverage for curative treatment. So those are the main differences. This is a new way of thinking about palliative care. Before palliative care was really developed as a specialty, and what happened was only hospice palliative care was promoted, and what happened was that you received disease-modifying treatment until the time that you had a 6-month prognosis, and then you received hospice palliative care until you died. The new model, the new way of thinking about palliative care is that palliative care should begin at the same time as the diagnosis of a life-threatening condition or debilitating illness or injury, and that it should coexist and be offered simultaneously with disease-modifying treatment, curative treatment. And then at the moment where a hospice referral is made, typically that disease-modifying or curative treatment ends. You receive purely palliative care, and then the hospice program allows for 13 months of bereavement support after a patient dies. So So treatment continues with the family after biological death occurs. Next slide. So let's talk about what makes healthcare quality care. And this is from the National Quality Forum, the Institute for Healthcare Improvement. And quality care is universally defined as care that's patient-centered, is beneficial, timely, safe, equitable, and efficient. So let's look at whether palliative care is beneficial. This is a study that was really kind of a landmark study that rocked the medical community. There was lots of press about it last September. So this was a study that compared patients receiving simultaneously standard cancer care plus palliative care and compared them with patients who received standard cancer care only, and this was for lung cancer. And what they found was that the palliative care and standard cancer care patients had improved quality of life, reduced depression, they had reduced aggressiveness, and the definition of aggressiveness is there: chemotherapy less than 14 days before death, no hospice care or a referral to hospice that came only 3 days or less before death. And they also, and this is what really rocked the world, was that they had improved survival. They lived longer. Okay. So, next slide. Is hospice beneficial? Well, hospice is associated with the highest family satisfaction among last places of care. And hospice is also associated with longer survival. 81 days with congestive heart failure, 39 days with lung cancer, and 21 days with pancreatic cancer. Is it efficient? Well, it is efficient because it matches the care received to patient goals. So here's a study that was done that talks about how conversations of goals not only reduce costs, but improve quality. So they looked at 332 seriously ill cancer patients, and in patients who had a prognosis and goals of care conversation, they felt that care was better, that they found that there was a lower risk of complicated grief and bereavement, there were lower costs and less aggressive care. Hospice also reduces costs. Hospice reduces expenditures in the last year of life by an average of $2,309 per beneficiary. So do palliative and hospice care improve quality? Yes, they're both patient-centered, they're both beneficial, they're both efficient, they're both safe. The only things that they aren't are equitable, and there are lots of reasons for that, which we can talk about later. And they're not, let's see what the last one was. They're not timely, because in most cases, hospice referral and palliative care referral occur too late. Okay, next slide. So let's look at our second patient, the patient who had the rapidly progressive neurodegenerative disease. His care was patient-centered, his goals were defined and met, it was beneficial, his symptoms were managed, his family was given adequate support, it was timely, it occurred at the moment of diagnosis and continued through death and bereavement, and it was efficient because it avoided unwanted treatments and hospitalizations. Next slide. So I'm really excited to announce that in Whatcom County, we, after many years of work, have received a grant from a local family foundation to begin an inpatient palliative care consultation service. We've actually hired our first physician. She is an amazing woman coming to us from UCSF. She will begin on the 16th of September. We also plan to have, as part of our palliative care team, a social worker, a chaplain, a nurse coordinator, and an administrative assistant. The other thing that we've embarked on recently is a community-wide advanced care planning project. And we have a grant actually from the same family foundation to begin exploring how to bring a community-wide advanced care planning project to Whatcom County. And the grant funds recipient for that initial exploratory grant was the Whatcom Alliance for Healthcare Access. And we're going to use the Respecting Choices model. So now I'm going to talk to you about that a little bit. So you've heard a lot about La Crosse, Wisconsin, all throughout Mike's talk. And what makes La Crosse, Wisconsin unique? Well, they implemented an advanced care planning model, and it was implemented collaboratively by the healthcare organizations in La Crosse. And since then, it's been implemented by 55 organizations nationally and internationally. And it uses an integrated, organized approach to advanced care planning. So it creates informed advanced care plans for future health care. It documents these plans in a uniform manner. That's really key. It makes sure that they're available to physicians when needed. And it ensures that treatment that's given is in accordance with the patient's preferences. So here are the results of Respecting Choices in La Crosse, and they've since been duplicated. The most recent study I read where they took the Respecting Choices model and duplicated that was in Australia. So in La Crosse, 99.4% of patients admitted to the hospital had an advanced care plan. By contrast, in Bellingham, it's about 35%. 93% of patients had documented specific preferences about CPR. 99.5% of the time, almost 100% of the time, the preferences about CPR and hospitalization were consistent with treatment decisions. And, as you found out from Mike, La Crosse, Wisconsin had the lowest utilization of hospital services in the nation during the last 2 years of life. And it also had the lowest Medicare cost of care in the nation during the last 2 years of life. So I'm going to talk a little bit about the Respecting Choices model, and then I'm going to stop. And we're going to have this more of a conversation about conversations before the crisis, how you have these conversations, tools that are available to you, and I'm hoping that we can have a lively discussion about it. But the Respecting Choices program essentially has 3 stages. And the first stage, which they call First Steps, is to normalize advanced care planning, which is a little bit of what I hope to do here today. So the First Steps stage of advanced care planning is located in the community. And they're conversations that are not only between physician and patient, but they're conversations that happen in lawyers' offices, they happen at adult day health, they happen in Alzheimer's support groups, they happen from the pulpit, they happen with parish nurses, they happen all through the county. And during that First Steps, the goal is to ask really healthy, middle-aged people, primarily, 50-some-year-old people, have you thought about what you would want to happen if you had something catastrophic happen to you, if you were in an automobile accident? It's kind of the Terry Schiavo scenario. What would you want to have happen if you were all of a sudden incapacitated? And just to get people thinking about that, hopefully complete a living will, and complete a durable power of attorney for healthcare, the most important decision you will make. The next steps is disease-specific advanced care planning, which occurs more often in doctors' offices. And the last steps is the POLST, which is the physician order for life-sustaining treatment. And that occurs primarily in patients who have a year to 2 years to live, okay? And I brought copies of Durable Power of Attorney for Healthcare, a living will, and the physician order for life-sustaining treatment, and I think they're available on the table out there. I did not bring a copy for everybody, but they're easily downloaded for free from the Washington State Medical Association website. So, I think Mike and I are ready to take some questions now.
Thanks very much. Now, we have Skip Williams and Chuck Foster going around, and we're open for your questions. Remember, it's a hard topic. Your question may be hard. Maybe you feel better writing it down, but we're among friends here, and we get the courage to come anyway, so we'll start right off.
Thank you for your presentation. And some years ago, I was introduced to this 5 Wishes program. Could you explain if that's still appropriate and how we could go about having the 5 Wishes presentation to make this all very real to us?
Well, okay, can everybody hear? 5 Wishes is a great community resource. There are free 5 Wishes workshops that happen about once a month in Bellingham. You need to, they're usually offered at St. Luke's, the Health Education Center. There's typically some publicity about them. If you go on the St. Luke's Foundation or the Health Education Center website, I'm sure you'll be able to find some information about them. The workshops are, they're funny. Sometimes we have 1 or 2 folks, sometimes we have 50. They're put on by Karen Bonakita, who's a nurse manager at the hospital, and also the nurse director for the hospice and cancer programs. She's really bright and knowledgeable. And also 2 hospice nurses help us on. They're really wonderful programs, and they're a great place to start thinking about your wishes. Approximately 5,000 people have gone through the 5 Wishes workshops in the last 5 years or so that they've been offered here in Bellingham.
Over here.
I'm wondering, you had mentioned the downloadable forms from the Washington State Medical Association. Are those applicable across the country for people that are traveling and might get in accidents?
Well, I guess the short answer is no. But they certainly, I mean, if you have a copy of your advance directive, you know, in your wallet or glove compartment,
Or with my sister?
Pardon, or with a sister, then most institutions across the country will honor those. In Washington State, there's no notary required for either document, either the durable power of attorney for healthcare or the living will. In other states, there is a notary requirement. And the POLST is not honored in every state. The POLST, there are, not every state is what we call a POLST paradigm state. Washington and Oregon have a POLST, and there are many other states throughout the country who have a physician order for life-sustaining treatment. Not 100%, so.
Thank you. Before we ask the next
the next question. A brief question. Can you tell us in 1 or 2 sentences what the 5 Wishes program is?
The 5 Wishes program is essentially a program that talks about, that asks you to think about basically how you would like to, first of all, it asks about various aspects of interventions that you might want. But then it asks things like, what would I like my funeral to be like? How would I like to be treated? Do I want to have music playing as I die? Do I want to be massaged with scented oils? Those kinds of decisions. Who do I want to make decisions for me?
Okay, thank you.
All of those kinds of things.
We have a question.
Thank you both for your presentation. As a recent hospice volunteer, I've learned that people access our services way late. And now as educated people, how can we encourage family members in the community to find out more about your services and get there earlier, where hospice can really do more help in the last few days?
Well, one of the things that we're hoping is that with this, with the palliative care inpatient service happening, that there will be more awareness about palliative care. But the other way really is to have all of you demand it, because most major changes in how healthcare is practiced in this country really are driven by consumers. So if you look at, for instance, the family-centered birthing movement, that was all consumer-driven, and birthing and dying are both have lots of things in common, and so if you want to change how people die in this country, you have to demand that change. Physicians and the medical establishment tends to be a little change resistant. And so you have to really demand that change. So we're hoping that this whole advanced care planning, I mean, look at what happened in La Crosse, Wisconsin. So we're hoping that as we roll out this community-wide advanced care planning project, and people start having these conversations before the crisis more often, that people will also come to hospice services earlier.
Okay, over here.
Dr. Jacobson, you mentioned that I think when one opts for the hospice care, that insurance for any curative procedures had to be surrendered. Could you explain that a little bit more?
Well, the Medicare hospice benefit, which is a Medicare entitlement program, essentially requires that 2 physicians certify a 6-month prognosis or less, and that you give up curative treatment in exchange for palliative treatment. So that has been a significant barrier to people entering hospice in a timely fashion, because there are a lot of people who don't want to give up their curative treatment. And so the ability to offer palliative care is a really extraordinary, and it's very exciting that we're going to be able now to start treating people long before they have to give up their curative treatment. Now, there is an exception to that. For patients who are not Medicare beneficiaries, who are younger than Medicare age, they have had access to hospice services And what hospice does then is provide under their insurance plans, and hospice provides core services, and the insurance company often will continue to pay for curative or life-prolonging care. But that option is not available to Medicare beneficiaries. So,
We have a question here.
Asimov said that the difficult times of transition between life and death, palliative care makes that transition easier, but it does not assure death with dignity. And my question relates to assisted suicide for the terminally ill, and what the current position of Peace Health is on that as far as their doctors prescribing the medication needed to allow one to die with dignity.
where's that? I told you that there would be this question. So basically, Peace Health, as provided by the law, has chosen to opt out. And the reason why they've chosen to opt out is that the Catholic position is that suicide, and they consider it suicide is immoral. So they are conscientious objectors, if you will. They believe that any direct referral to an agent who provides information, and any actual participation in writing a prescription, that is material cooperation with an act that the Catholic Church believes is immoral. So we're not going to change that position ever. And so Peace Health, in cooperation with the County Medical Society, and actually in cooperation with the Compassion and Choices people, has made available to the citizens of Whatcom County a source for referral to not only to Compassion and Choices, but to physicians who can and are willing to prescribe lethal medication. Now, that does not preclude hospice from those patients being also hospice patients. The hospice personnel cannot be present when the patient ingests the medication. But we at hospice minister to the dying, and it doesn't matter how they're dying. If we started to make distinctions between, there are certainly people could make an argument. I'm sure there are physicians who could make an argument that chronic alcoholism is a form of suicide, that non-compliant diabetics are suiciding. We've had patients suicide on hospice before death with dignity. We've had patients on our hospice service utilize death with dignity, and I really feel that there are sufficient opportunities in Whatcom County for people to access the law, and and although I'm not a Catholic, and I perhaps have a different view of things, I very much respect the Peace Health's position on the issue, and as a conscientious objector. So,
thank you for your presentation. question. I work in long-term care as a medical social worker. I think it's important to emphasize from my frame of reference, your wishes as a consumer drive the healthcare program. And by filling out your power of attorney documents, your physician's orders for life-sustaining treatment, you are making clear to all your providers what you want done and how you wish to be respected in the process that we do together. But the other part that's important to know is that nothing is cast in concrete. You can change these documents whenever new information or new situations develop. Additionally, you can ask hospice to be partners in your care. And this has happened to us a number of times in our skilled nursing facility. Someone will come in with hospice, and we form a partnership to assist this person in the final months, and guess what? They get better. And hospice respectfully removes themselves, and these people, we have one right now who was supposed to die 15 months ago, and she's going to the fair next month. So know that it always can change, and you are always in charge. Thank you.
So there's no question there. We have one over here. Please.
While your presentation was general, I have a specific question, which might be outside the framework. You mentioned resuscitation, for example. I had heard that most physicians have a do not resuscitate order, and I was wondering, is that really true? And is that your position statement? And the other issue you mentioned was a respirator. While my father was suffering from complications due to hip surgery, the doc cautioned me, well, it's easy to put them on, but it's hard to get them off. And so I wonder, that might be too specific a presentation, but I wonder if you would address those two.
Well, I'll try and sort of be very general about resuscitation. I don't think that most docs have a do not resuscitate order. Resuscitation was essentially designed for young people, and by young I mean my age. Young people who drop dead on the tennis court or at the racquetball club. Those are the people that resuscitation works on. Resuscitation does not work if you're 83 and have multiple medical problems. You may survive the resuscitation effort, but the statistics on survival to hospital discharge and survival for 1 to 2 to 3 months post-hospital discharge are really grim. So most physicians I would say that probably many physicians who are elderly and retired have a do not resuscitation order. Yeah, but most physicians, I would say, probably want to be resuscitated.
I meant
elderly physicians, yeah. Most elderly physicians don't have do not resuscitate orders.
Well, again, I think it's personal, but I will share my own personal experience. Several years ago, I was to have surgery. Being a physician, I knew the potential complications of surgery. And I sat my family down. It happened to be Christmas, and my children were there. My wife was there. Unexpected to them, I sat them down with a letter I had written and asked them to sign it with essentially that order. But that's personal. It's because of my knowledge about healthcare. It's because of my own personal conviction that I had a good life, and I know feel compelled that it's prolonged, particularly unnecessarily. So, as I say, personal.
Thank you. We have one last question.
Yes. I recently had a routine medical procedure, a colonoscopy, and in the documents that I have signed prior to the procedure, it said very specifically that they do not honor advance directives, and if anything untoward happened during the procedure, that they would make every effort to sustain life on and on. And my question is, are there other places where we should be watching for that kind of language, and is there anything we can do about it if we already have wishes in place?
Most elective surgery, that's a stipulation. That and the reason for that is that anesthesia is considered resuscitation. So it's considered, if you look on the pulse, it's considered full treatment. So anesthesia, for one thing, is considered resuscitation, but also if you arrest during an elective surgical procedure, they will resuscitate you. Now that doesn't mean that once you're out of the surgical procedure and you are on a ventilator or on, that you can't have it withdrawn. And we do that all the time. And I wanted to go back to that comment about it's hard to get people off a respirator. It's hard to get people off a respirator who are old and ill and have underlying lung disease. But we will turn off a respirator without, you know, if the family and the patient have clear wishes and somehow they wound up on a respirator and they didn't want to be, we will turn it off. And that's very consistent with, you know, withholding and withdrawing treatment are ethically and legally equivalent, and we withdraw treatment all the time at St. Joseph Hospital.
Great, thank you very much. Just one question. Do you have anything to recommend if people want to read something further on this? Gail Sheehy has a book on passages of this sort, and there's an article in New Yorker last August, I think, Guadney's article on letting go. I'm not sure if there are other things that you think might be available for people that can read more about it, get comfortable as you do this. And obviously there's materials outside as well. So anything off the top of your head? Okay, thanks very much to our speakers. It's been really wonderful. Again, a difficult issue. And I'd like to give them a gift of Whatcom Places 2 as a token of our appreciation of what you've done. Thank you very much, Meg. Good night.